In this lecture, we will go over the cohort designs in much more detail that you have seen before. We will start with the things that you are familiar with, and then we will go to the things that are new and will be added to the learning outcomes in pharmacoepidemiology. So here we're talking about cohort, and the reason you have this graph over here is because the name cohort came from the Romans, where fighters used to aggregate together in forms of cohorts. As a reminder, um, the three big categories of study designs, and an experimental, which basically include the RCT. There are other types of experimental design, the crossover design, the factorial designs, um, the also the quasi-experimental designs that we have discussed previously last year. However, in this year, we're going to focus on RCT. In the non-experimental design, we have two major design, case control design and the cohort design. This lecture is about the cohort design, which resembles a lot the RCT, except that it's not an experimental. So first thing we're going to start with is the things that you should already know from the previous year. Um, First thing is that in a cohort design, the groups are defined based on whether they are exposed or not. So this is your starting point. The selection of the participants based on whether or not they're exposed. We see if we follow up exactly that happens in RCT till the outcome occur, and those that occur are new cases, therefore considered to be incident cases, and therefore can be used to calculate relative risk or risk ratio, which is about the same thing. At the time where the study starts, everybody should be free of the disease, meaning that prevalent cases are not allowed. And the follow-up can happen either in real time or in virtual time. And we call this to be concurrent versus non-concurrent. Cohort design in general are prospective designs because you're starting with the exposure and you're following up till the outcome occurs. More things that you're supposed to know already. The obvious advantages of cohort: establish the temporal relation between the exposure and the outcome. They're good to study rare exposure since you can find the rare number of those that are exposed and follow them up, and find a group that is not exposed and follow them up. Like, for example, studying those taking certain medication. A cohort is a good study design. Can study the effect of the exposure on multiple outcomes. And you start with one exposure, and as you're doing the follow-up, for example, a certain medication, and as you're doing the follow-up, um, you may have multiple side effects, and therefore you can look at those multiple side effects. The example here is the exposure to oral contraceptives and its effect on risk of breast cancer, ovarian cancer, myocardial infarction. So one exposure, multiple outcome. That design allow you to do that. Um, Also, cohort has some problems or disadvantages. It requires a large number of people to be followed, and as such, are very time consuming and expensive. Obviously, every time you're going to do a follow up, you're going to end up with spending a lot of time and spending a lot of money. It has a problem, which is the loss to follow up, because it takes time, and therefore people travel, people change their location, people change their address, and you might end up losing people. Or maybe people stop coming to the clinic that they used to come to, ending up with loss to follow up. And typically, it's not good or suited to study rare outcomes, because if you want to study a rare outcome, you would have to recruit a large number of people to find the very few that will develop the outcome. Okay? All right. The general setup of a cohort looks like this. You select your sample based on whether they are exposed or not exposed. At the beginning, ما حدا عنده outcome. We do the follow-up over time, and as time is progressing, cases start to occur, and you keep record on that to calculate incidence incidence rate or incidence density. What are the new things that we're going to discuss that we haven't had the chance to spend a lot of time in previous courses or in previous lectures? these are the 6 things that we will cover today. First, prospective versus retrospective, يعني concurrent versus non-concurrent. Oh, that's the appropriate terminology. You've seen this before, but we're going to give an example and we're going to talk about it a little bit. Second thing that is very important is how do you go about selecting your exposed group? How do you go about كمان selecting the non-exposed group? And also, how do you go about ascertaining the outcome? How do you go about ascertaining the exposure? Yani making sure the outcome occurred, making sure the exposure actually really was present. And number 6 is the role of bias. By the way, ascertaining outcome and ascertaining exposure, this is an important characteristics of any study design. In any study design you're reading, you should ask yourself, how did they make sure that the outcome is present or the outcome is not present? How did they make sure that the exposure is present or not present? Even in an RCT, you ask yourself, how did they make sure that the patients randomized to be taking the medication actually were taking a medication? And how did they make sure that the outcome, which could be مثلا a certain cardiac occurrence, how did they make sure that it actually occurred? Whole aspect ascertaining the outcome and exposure have a major role in the quality of the data that you obtained and therefore the quality of the conclusion that you're going to generate. And this is true in RCT, in cohort, well, in case control designs. Janek, when you will see the case control lecture, you will also see that we are going to talk about ascertaining outcome and ascertaining exposure. In the case control, the setup is different. You're selecting cases and control, and therefore you ask yourself, where do you find the cases and when do you find the non-cases and in the control? However, in the cohort, you ask yourself, where do you find the exposed and where do you find the non-exposed? All right, so let's go over these 6 points and see if we can shed light on all of them. So point number 1 is concurrent and non-concurrent. And you heard me previously saying that these have been mistakenly labeled as retrospective for the non-concurrent and prospective for the concurrent. Both of them are prospective, okay, but concurrent, non-concurrent. So the non-concurrent, this is when studies start, both outcome and exposure had occurred. يعني نحن عم نجي مثلا بال 2020 we're starting a study, things have happened. However, researchers use records to go back in time, establish the exposure regardless of the outcome. So first you find the exposed and the non-exposed, and then you do your follow-up over the records. So that what I call virtual time till the outcome occurs on papers, yani as documented. Here's an example. A study looking on the effect of asbestos was done in 1965. The participants were asbestos workers working in 1948 to 51. Death certificates were obtained and all occurred between 1948 and 63. So you notice that the study started in 65, the exposure came between 48 to 51, and the outcomes started between 48 all the way up to 63. Yani the outcomes were occurring before 65. However, all of this was on record. Lung cancer mortality rate were compared in the asbestos workers to the cotton textile workers and to the general population rate. So if you look at the graph here, this is when the study starts in 1965. However, on records, they had records of the asbestos workers and the cotton workers and the general population. Okay, 1943, the exposure to asbestos was ascertained. They knew based on the record and the whole workers were exposed. Cotton workers were not exposed because they do not work with asbestos. And then they did follow up on paper based on the death certificate, finding every death certificate for every worker and figuring out if it was due to lung cancer ولا لا, and jotting down on the records if it was or not, and calculating the lung cancer mortality rate for each of these 3 groups, calculating hence the risk in every group and calculating the relative risk and comparing the groups. Here's another example. This one is from pharmacoepidemiology. So antihypertensive drug have been linked to new onset of diabetes. Okay. So عندنا exposure اللي هو الانتيهايبرتنسيف والاوتكم is a new onset. بدنا نعمل cohort, but it has to be a retrospective. Sorry, I'm saying retrospective حتى أنا مغلط. It has to be a non-concurrent cohort. Okay. So think about how you're going to do the study. Identify those exposed to hypertensive drug. Remember, that's the starting point. You need to find a place where you have records of those taking the medication and those not taking the medication. Where would you go to find these people? Where would you go to find people that are taking the medication and not taking the medication? So think about it. As until you're asked to do the study, where would you go to find people that are unhypertensive and non-hypertensive? Okay. Now, make sure that when you find them, you're not looking at whether or not they have new onset of diabetes. You're just looking if they're exposed or not. After you find the exposed group, okay, you need to find a group that is not exposed, not taking the hypertensive. Come in. Where would you go to find this group? You need records that that show a group is taking the antihypertensive group and group not taking. Now, once you've established these two groups in the records in the past, then within every group you start looking for who developed diabetes. طبعا the diabetes has to be a new onset of diabetes, meaning it has to start after they started taking the hypertension, so that it's a new onset. Okay. All right. So let's me بس صلح this. The reason I'm giving you this example because basically there is an article that I want to share with you. So this article was published in 2013 and it's titled A Retrospective Longitudinal Cohort Study of Antihypertensive Drug Use and New Onset Diabetes in Taiwanese Patients. هلا again notice انه قالوا retrospective longitudinal at the same time. نحن بنقول non-concurrent prospective, but that's fine. If you read the abstract, first of all, I'm يحكوا على the link between antihypertensive and NOD, يعني new onset of diabetes. Then they say we conducted a retrospective study. For us, it's not a retrospective, it's a non-concurrent of hypertensive Taiwanese patients receiving hypertensive drug treatment between 2006 and 2011. So that's the follow-up من 2006 ل 2011. Okay. Clinical information and laboratory parameters were collected by reviewing their medical records. We estimated the odds ratio of the new onset of diabetes associated with hypertensive drug use, and the non-diabetic subjects served as the reference group. So they calculated an odds ratio, مع إنه نحن we know that if you're doing a cohort, you can either calculate an odds ratio or a relative risk. So حتى لو if they're doing an odds ratio, the interpretation of this odds ratio would be built on the odds of the outcome in the exposed versus the odds of the outcome in the non-exposed, if you remember the lecture about the odds ratio. Okay? A total of 120 cases were identified in 1,001 hypertensive patients during the study period. The risk, هلا لاحظوا, though they're talking about odds ratio, here بلشوا يحكوا على risk, and we know if you're calculating an odds ratio, you're not supposed to say risk. However, I told you that a lot of time people are going to calculate odds ratio and they're going to interpret it as a risk, which is not always true. The only time you're allowed to do this if you meet the three criteria we talked about in the lecture where we talked about the odds ratio and the relative risk. But since this is a cohort study, يعني all the cases are new cases, new onset. These are incident cases. I wonder if they actually meet the criteria to interpret the odds ratio as if it's a relative risk. But let's continue. So they're saying that the risk of the new onset of diabetes after adjusting for sex, age, and baseline characteristic, هذه الفكرة adjusting, this is something that we will talk about maybe in the lecture to come, was higher among the users of the antihypertensive drug, وطلع معهم an odds ratio of 1.65 with a confidence interval of 1.12 to 2.45. Okay, so if you want to interpret this 1.65, this is a 65% increase in the odds of new onset in the exposed versus the non-exposed. Well, confidence interval does not cross 1 and therefore it's statistically significant. So also there is another odds ratio for the calcium channel blocker. Come in, this odds ratio is 1.96 with a confidence interval of 1.01 to 3.75. Come in, we can interpret this odds ratio as a 96% increase in the odds, and it does not cross 1, the confidence interval, and therefore it's statistically significant. So we are comparing the users to the non-users. That's typically what's done in a cohort. We're always comparing exposed to the non-exposed. Okay? Other antihypertensive drug classes were not associated with the risk of the NOD. So they only found an association in two, اللي هن the calcium channel blockers and the thiazide diuretic. The point is they did it using non-concurrent. They went back, they found records, and based on the records, I'm going to follow up in the past till the occurrence of the outcome. And again, remember this was published بال 2013. Probably the analysis was done by 2012. So the follow-up was من 2006 ل 2011, which makes sense. The other type of cohort, this is the concurrent cohort. This is where you're going to follow people in real time, which is easier to conceive. Okay. So the example, بعدنا with the asbestos cohort. You remember the study was done in 1965. So what they did after they did the retrospective cohort, retrospective, I should say, the non-concurrent cohort, عملوا a concurrent cohort. So in 1967, a follow-up study was done. Asbestos workers were followed to the 75, so 7 years, to compare their mortality rate as compared to the general population. Okay, so after they done the non-concurrent, they actually did another study, which was a concurrent study. Again, we have an example of a concurrent cohort that is also from pharmacoepidemiology. And this one is kind of like a strange example. It's about medication errors. So they call it a prospective cohort. On the handwritten and a computerized physician order entry in the intensive care unit. Okay, so it's a prospective cohort. All cohorts are prospective study of handwritten and computerized physician order entry in the intensive care unit. Yani, the title is medication error. So try to think about مين in the groups, يعني exposed or non-exposed, شو الoutcome, and think about how they did it prospectively. Think about it, and then we're going to move to the actual study. So this is the actual study. It's coming from critical care. And the study title is Medication Error, a prospective cohort study of handwritten and computerized physician order entry in intensive care unit. That was published bil 2005. You probably have figured it out. Exposed or non-exposed is what type of order the physician are doing. Are they doing it by hand or are they doing by computerized? And الأوتكم هو إذا في medication error ولا لا وفي follow up. So let's look at the abstract. The study aimed to compare the impact of computerized physician order entry. So compare that to handwritten prescription on the frequency, the type of medication error in the intensive care unit. So if you look at the method, the study was conducted in London teaching hospitals in 22 bedded general ICU. The sampling period was 28 weeks before and 2, 10, 25, and 37 weeks after introducing the CPOE, which is, I think, the computerized physician order entry. So they looked at what happened before, and then they introduced it, and they looked at what happened after. The total proportion of medication error was significantly lower in the CPOE than the HWP, yani the handwritten. And they're reporting the error rate 4.7 versus 6.7. And therefore, you can actually calculate relative risk. And in this example, the relative risk ought to be less than 1, and it is, because the rate is 4.8 in the not in the exposed versus 6.7 in the not exposed. and the p-value is less than 0.04, yani statistically significant. In this case, they opted not to calculate the confidence interval, just to look at the p-value, and the p-value came out to be statistically significant. All right, so if we were to compare the non-concurrent to the non-concurrent is faster, cheaper, it's good for long latency diseases, بدل ما نعمل follow-up for 20, 30 years. However, it depends on records. It cannot look at all variables of interest. You only have those that actually are recorded, and cannot evaluate all possible confounders. The concurrent, you collect more information and you can assess the role of confounders appropriately. So again, here I'm making a note that please note that prospective and retrospective refers to when was the exposure ascertained in relation to when the outcome occurred. Thus, cohorts are all prospective versus case control, which are retrospective. You've already heard me say that a lot of time. And I already told you that in literature, authors confuse non-concurrent with retrospective. So that is part one of the lecture. We compared the concurrent versus the non-concurrent cohort. Part two talks about selection of the exposed population. Remember, you have to think about where do I go to get my exposed, where do I go to get the non-exposed. So where do I go to get the exposed population? This choice of population heavily depends on exposure itself. If it's a frequent exposure or is it a rare exposure? Yani, are you looking at something like smoking, which is quite frequent, or are you looking at a case of مثلا statin, taking statin? Well, if it's a smoking, then you could probably go in the general population and find your exposed. However, if you're looking at the statin or maybe another type of medication, then you need to find them, and then you have to look in a specific group of individuals. Okay, so that's the difference between looking in the general population and a specific group. If you look into the general population, then your sample is more likely to be representative. Okay, your results could be generalized. However, they are harder to recruit. إذا أنا بدي أعمل cohort على smoking, بدي أروح فتش على smokers, and I want to include them in my study, and I want to also make sure that they agree to participate, it's going to be much harder than if you go to a specific group of individuals. Specific group could be مثلا a group of people that altogether they are exposed. كلهم مع بعضهم they are exposed. مثلا I want to look at the risk of being vaccinated for hepatitis B. Or is it hepatitis C, I think, the one that is required from nurses. So I go to nurses and I recruit the nurses knowing that they're all exposed to hepatitis C as a vaccine. It will be easier for me to recruit them. It will be easier for me to do the follow-up. Okay, so they're harder to recruit. The ascertainment of exposure and outcome is harder. كمان لأنه it's a general population. It's always harder than if you have a specific group. If you have like nurses, they're easy to find. They're already aggregated within hospital. They already have their medical records, so it's much easier to do. And it's more prone to something called the loss to follow-up bias. هنحكي عنه at the end of the lecture. But loss to follow-up is a problem with cohort studies. لما بتعملوا follow-up, people change their address, as I mentioned. People مثلا they stop coming to this clinic where you were using it to capture them for the follow-up. People مثلا they change country, and then you follow them. You lose them, and then it becomes a problem if you end up losing a big portion of your sample. So one way of getting your exposed is the general population. Another way is to go into special exposure group. So help identify etiological agent that might be missed in the general population. مثل ما قلت لكم, if you go to hepatitis C, يمكن the general population is not vaccinated against that. So where would you go to find them? You have to go to a special group. إذا نحن we're interested in looking at مثلا exposure to very high noise, as an exposure for hearing loss. Where would I find them in the general population? لا, I have to go to a certain job where people are exposed to very high noise. مثلا example of asbestos اللي مرق معنا. Where would you get people exposed to asbestos? مشان هيك they went to manufacturing companies. حتى مثلا example that you may have heard me talk about, the vinyl chlorine exposure. They had to find كمان a manufacturer of that product. So every time the exposure is very specific to a certain employment, then you have to go to that employment to get them and to follow them up. And that is kind of like similar to when you're doing a pharmacoepidemiology, Enrica, because you're looking for a group of people that is taking a specific drug. So then you have to find these people. So special groups هن مثل nurses, مثل physicians, union members, and are used to obtain better quality data. And they usually also they give you a higher response rate. If you remember, I've talked about in PHA 41 last year, I've talked about two studies a lot. The nurses study and the British doctor study. إذا مذكرين اثنيناتهم كانوا cohort studies. واثنيناتهم كان فيهم follow up. So they followed up nurses and they followed up physicians. The British doctor study كان exposure on whether or not they're taking aspirin. وطلعوا على outcome اللي كان heart disease. Whereas the nurses study they looked at whether or not they're using oral contraceptives. وطلعوا على think like cancer. So both were example of special groups. Okay, so that concludes selecting the exposure. هلا you want to select your comparison group يعني in the non-exposed. Where would you go to find the non-exposed? Again, the comparison group should resemble the exposed group as much as possible with regard to all aspects except the fact that they are not exposed. هلا عندي هون between parentheses as we mentioned in the case control design, it depends on which video you're watching first, the case control or the cohort, but the same idea applies. Okay, every time you're selecting two groups, whether it's exposed or not exposed, ولا cases versus non-cases, you'd like for these two groups in their selection procedure to be the same strategy in the selection as much as possible, with the except that إذا exposed التاني جروب ما لازم يكون exposed، وإذا case control هذا الجروب عنده ال outcome, the other one should not have the outcome. So sometimes the cohort is selected and then the exposure is ascertained. This is what happens مثلا in general population. You take a group of مثلا سكان منطقة كاملة and then you ask them if you smoke or not وبتعملوا الفولو up. مثل الفيزيشن they took British doctor study مثلا British doctor study they recruited all the British doctors and then they started asking them if they smoke or not, if they are taking aspirin ولا لا. Okay, وعملوا follow up لحديت ما صاروا يطلعوا على outcome which was lung cancer mortality rate. One of the major known cohort study is the Framingham study. And as a P3, you should be aware of the Framingham study. The Framingham study is the mother of studies where our knowledge about heart disease comes from. Framingham is a town, and this town everybody has been followed for 3 generations. يعني بلشوا بالgrandparents, parents, وهلا صاروا in the 3rd generation. And basically what they did, they said, we're going to follow everybody. So everybody in the town is followed year after year after year after year. And they're looking at anything. So مثلا يلي عندهم blood pressure versus يلي ما عندهم blood pressure, and they followed عم ليصير عندهم coronary heart disease. يلي عندهم high blood pressure من يلي ما عندهم، من يلي عندهم cholesterol ويلي ما عندهم, and they follow them up till the outcome occurs. Okay, so that is one strategy. Of course, that's not always feasible. Another thing that you have to think about when you're picking your comparison group, yani the non-exposed group, is whether you go for internal or external comparison. What I mean by that, internal versus external, this is specifically when you are going through a specific group to get your exposure. Okay? So the internal are those selected from the same site. The external are those selected from a different site. وحنضرب أمثلة and see if it makes sense. So internal exposed مثلا are those users of medication and they are insured by GlobeMed. Okay, مثلا يلي عم ياخدوا شو بعرفني أي دواء for heart failure and they are exposed by GlobeMed. So it's easy for me to find users of the medication through the insurance because that's where I will find them. An internal comparison group هن حيكونوا group that are also covered by GlobeMed. However, they're not taking the medication. Okay, so the good thing about this method is that بما انه both of them are GlobeMed insured معناتها they are both probably they have the same kind of socioeconomic status, the same kind of education, the same type of health service utilization in the past, because they kind of come from the same place. So that's an internal group. um, for special exposure groups, sometimes internal comparison is not feasible. Thus, an external exposure group is selected. So أوقات لما everybody in your special group is exposed. So I'm not an example mine workers. So رحنا على mine workers, we wanted to select them لأنه they are highly exposed to noise, to dust, to CO2. Okay? إذا بدي internal comparison group، يعني من الماين workers بدي اخذ ناس not exposed to noise and not exposed to dust and not exposed to CO2, it might be very hard. ما هن كلهم are exposed. So therefore you might need to go to another group that are not mine workers to get a non-exposed group to be followed up in time and see what's going to happen to them. So that is called an external group. كمان the example of the hepatitis C, I think it should have been مش B, I don't remember. So if I went to nurses to get my hepatitis vaccinated لأنه they are required to be vaccinated, I cannot get an internal comparison group because ما في بالnurses a group of nurses that is not vaccinated أو إذا في they're very very small number, and therefore I would need to go and find a non-nurses not vaccinated to serve as my comparison group. So in this case, an external group is to be selected. مثلا, you can go to the general population to get the non-exposed, or you go to a similar group. So for example, for my mine worker, I can go to postal service workers. حاول من عند هول جيب a control group. أو مثلا للنurses بدل ما أروح على general population to get my comparison group, I can go and find them among nutritionists. مثلا nutritionists كمان they kind of have like health education. كمان they kind of like work with patients. So they might resemble nurses on some level. However, they're not nurses and therefore they're not required by law to be vaccinated. Okay? Hello. When you're doing that, you need to watch out for selection bias because an issue that always have to be in your mind, what if there is a very drastic difference between the two groups, not to do with the fact that one is exposed and one is not exposed, but to do with their other things, their education, their income, their okay. So another example مثلا إذا عم بعمل أنا special exposed group هن asbestos workers. I wanted a group of people exposed to asbestos. من وين بجيبهم؟ بروح على asbestos workers. However, all of them are exposed. So ما فيني جيب internal comparison group. I want an external comparison group. يا اما باخذ general population بس حدا ساعتها بيقول لي wait, general population في عندك highly educated, high income, holy workers, بدك تجيب ناس مثلهم. And therefore I need to get كمان workers but not in the asbestos. So I go مثلا and I get them from the cotton workers. So it's kind of like the same type of work, same difficulties, same hours. So I'm trying to get a comparison group that are not exposed but that are like not very different from them. All right, so more about the selection of the comparison group. When using the general population as a comparison group, there is always a chance of bias, since the general population might not be comparable to the special exposure group. And I mentioned that يعني your special group might be مثلا physicians. All the physicians are مثلا required by law to be ما بعرف taking لنقول aspirin, which is not true بس لنقول. So ما فينا نجيب an internal comparison group لأنه then كل الphysicians are taking aspirin, for example. Okay, so I need to go to the general population, but the general population does not resemble physicians. So بدنا نجيب ناس بيشبهوا الفيزيشنز بس ما ياخذين اسبرين. So مين هن اللي ما بيشبهوا الفيزيشن؟ هن اللي بيشبهوا الفيزيشن بس ما بياخذوا اسبرين. So you may say مثلا pharmacist, that could be مثلا a comparison group that is reasonable. ممكن حدا اللي engineers that as كمان in the same like level of education, same income, that كمان are not required to take aspirin. Okay? So that was number 3. Number 4 now, that's where it becomes important to make sure that your independent variable and your dependent variable, you're doing a good job at measuring these two. And you're not making an error, because every time you're making an error in the independent and the dependent, يعني in the exposure and the outcome, you end up doing something called a misclassification. يعني حدا who is exposed أنت ما لقطته إنه exposed, so you misclassify that person as not exposed, والعكس صحيح. Or someone who actually developed the side effects, however you fail to capture the side effect, and therefore you're going to label that person as not with side effects, and that would be also a misclassification. Okay, so I do start the lectures talking about case control design, because depending upon which lecture you're watching first, but it doesn't matter. What matters here is that we need as much as possible to reduce the error, yani the false. Otherwise, that will lead you to making the misclassification. So how do we go about ascertaining the outcome? How do we go about making sure that the outcome occurred? This is a cohort study. You're following up people till the outcome occur. So how do we make sure that the outcome occur? And 3 major ways. Records, especially if you're doing a non-concurrent. Self-report, sometimes it's good and sometimes it's not a very good measures of reporting outcome. And finally, direct physical examination, which it may be costly, but it's a very good way of ascertaining your outcome. And in fact, that's what they did in Framingham study. Framingham study اللي حكيتكم عنها, where they followed everybody in the town for year after year after year. I think every 2 to 3 years they had them go to do a physical checkup. I think it was covered for free. I don't remember, to make sure and know whether they developed any outcome. So medical records, مثلا X-ray, مثلا medical charts, مثلا prescription, or counting the pills, depend upon if they are available or not. For records, remember that we talked about it a little bit when we were talking in chapter, I think 4, which had to do with secondary databases. And secondary databases, your data is already there, and like how would you utilize the data? So it kind of like tie up a little bit to that point. Second one is self-reporting. They can self-report either using a questionnaire or an interview. So interview is like you have a person actually asking them a question and they're answering the question. So this is called an interview schedule. A questionnaire is like more self-filled. They fill it out on their own. All issues related to the quality of data collection should be addressed here. Yani make sure that when you're collecting the data, you're not biasing your interviewee, I mean. So if you're using an interviewer, you make sure that the interviewer is well trained, professional, respectful, asking the question in the right order, and like, I mean, we can spend a whole course on data collection. Also, you need to watch out for interviewer bias, for the validity and the reliability of the instrument. For those of you that forgot to monitor validity and reliability of the instrument, not of the study. So remember, a study has an internal validity or external validity. A study internal validity means that the study is protected against bias. External validity means the study has a wide generalizability of results. Here, I'm talking about validity of the instrument and the reliability of the instrument. And what that means, we talked about this in PHA 421. Reliability of the instrument means that the instrument produces replicability, replicates the result. So that instrument is going to give you the same results if you repeat it again and again and again, and therefore it's a reliable result. Validity of the instrument means that the instrument is actually measuring what it's supposed to be measuring. Okay? So if you're looking at side effects of medication and the side effects is مثلا لنقول pain in the abdominal area, then your instrument is supposed to measure pain in the abdominal area and not مثلا pain in the lower back. If your instrument is measuring pain in the lower back, then it's not valid because that's not what you want to measure. Okay? It might be reliable, but not valid. The third type is physical examination. You may take مثلا urine test or blood test, etc. Send them to the lab, or you may ask a physician to do the examination or a nurse to do the checkup. Obviously, when feasible, these are very good techniques of ascertaining the outcome. Another thing that you have to think about when you're ascertaining the outcome is the frequency. How often are we supposed to ascertain the outcome? Okay. Um, Sometimes one time is enough. مثلا, if I want to do a cohort on a PTSD, post-traumatic stress disorder, after the explosion that happened in Beirut. The explosion only happened once, so you either heard it or did not hear it. You either felt it or did not feel it. So whether you felt it or not, this is my exposure, not exposure, and I'm gonna follow you up like after 6, 7, 8 months and see if you have symptoms of PTSD. While this happened only one time, I don't need to ascertain the exposure multiple times. نفس الشيء مثلا إذا حدا was vaccinated. Again, the example of vaccination. The vaccination only happens one time. So I only ascertain it at one point in time, whether you're vaccinated or not, and that's it, right? Um, Unless someone who was not vaccinated at a point in time becomes vaccinated, then I need to capture that. There are other times when you need to do multiple ascertainment of the exposure. This when the exposure changes. Okay, مثلا smoking. You may be a smoker and you may stop smoking. أو مثلا you were not a smoker and then you start smoking. هون you need to do multiple ascertainment of the outcome. كمان مثلا exposure could be the exposure of using the medication or not. Being if you're using the medication appropriately ولا لا. So you may be using the medication appropriately the first 6, 7, 8 months, and then you start not using. So here, if you're doing a cohort, you may need to do multiple ascertainment every month, every 2 months, every year, depending upon the situation. إذا بنرجع للفرامينغهام study, I think if I'm not mistaken, they would require to have them back every 2 years, and maybe like every 2 years they would check on the exposure and on the outcome. So if the exposure could be مثلا high blood pressure with regard to the outcome being مثلا myocardial infarction. So every 2 years they measure إذا بعده blood pressure uncontrolled ولا controlled أو مثلا حدا developed a new blood pressure problem. Okay? So depending upon the type of exposure, you might do it only one time. You only ascertain the exposure one time, or you may have to do it frequently. Okay? So what is the effect of the exposure changing over time? So كنا عم نحكي sometimes exposure changes over time. So researchers should consider whether people can change exposure status, part of the analysis. So بيسمحوا للناس sometimes in their analysis to be moved from exposed to not exposed or not exposed to exposed. So somebody participating in a cohort, they could be for the first 2 years as non-users of the medication, and then after 2 years the physician prescribed to them the medication and they become a statin مثلا if it's a statin users, and therefore after 2 years of being in the study that person becomes a user. Then they have to move them from the not exposed to the exposed group. And remember we talked about this a little bit لما كنا عم نحكي على الانcidence density. So you're no longer looking at the individuals but individual time. So you put them multiply by the time. So whether they should be considered different profile of exposure status, so it's a continuous use, intermittent use, or dose effect. Also, what if age is an important factor that relates to how big an effect of the exposure has. So sometimes you can allow people to change their exposure, like I said. The time spent in an exposure is then calculated using the person years. Person years is a measure of unit of time a person spent in a specific group. So مثلا 10 exposed people that remained exposed to 5 years will result in 50 person years exposed. Okay, so this is enough about ascertaining the exposure. Now you have to ascertain the outcome. So, okay, I'm doing a follow-up. How do I know that people actually develop the outcome? So, عندنا two ways. One outcome that is widely used with death, you would be surprised how many times people look at death as an overall outcome. Um, حتى مثلا non-specific death. So you may look at vaccinated and non-vaccinated, and which is true. أو لا حتى for screening, people that were screened and people that were not screened مثلا for PSA, and they look at death in general, and prostatic cancer death. It's a very drastic outcome, but they still look at it. So death, you can use death certificate are good if crude death rate is the outcome. However, for cause-specific mortality rate, death certificates are not so good. So نحن حكينا على death وحكينا على how vital statistics keep records of death. So if you're going to look at general death in general, using the death certificate are good. However, if you're going to look at cause-specific mortality rate, like the leading cause of death, like the direct and the indirect cause of death, then the death certificates are not good. And if you want to take a guess why, be my guest. And I would say because there is a very bad the direct and indirect cause of death are very badly filled out. طبعا نحن حكينا على ICD-10 which can be used. If used, that will help a lot in reducing the error in reporting the cause of death. Non-fatal outcome, you need to find physician records, hospital discharge logs, registries, or even self-report, even clinical testing. مثل ما قلنا, you may ask your participant you may draw their blood or get a urine sample and send it to the lab. If you do that, it's going to cost you a lot of money, obviously. But it has its advantage. So we're still going on with the ascertaining of outcome. The nurse health study, so again, you've heard me talk about this. This is where they looked at the oral contraceptives, عملوا follow-up للwomen, and they looked at cancers, among other things. I think they looked at يمكن osteoporosis, we looked at heart outcomes. So when they did the nurse health study, they found out that self-reports are good for disease with clear criteria. A disease that is clearly identified, okay? You can use self-report. مثلا عندك hypertension ولا لا, عامل fracture ولا لا, في cancer ولا لا. These are easy, okay? But it's not very good for outcomes that are not easily identified. مثل المايكارديال infarction. هلا هون حاطين حتى lung cancer as an example. ما بعرف ليش breast cancer is an easy one to identify versus lung cancer. But anyway, the point being, you can rely on self-report most of the time, unless the outcome is tricky. If it's tricky, then you better do some testing. مثلا خليني أسألكم, إذا outcome is developing hypertension, would you trust people's reporting if they have hypertension ولا لا? حتى لو diabetes, would you rely on people reporting if they have diabetes ولا لا? The problem in both these diseases that these are called silent disease. معناتها some people have it and they do not know that they have it. So ما المشكلة باللي بيقول لك yes عندي hypertension, yes عندي diabetes. Well, probably they do have it. المشكلة بيقول لك لا ما عندي, because maybe 20% they do have it and they do not know. So هون بيصير عندك شيء اسمه misclassification, like we talked about previously, right? So misclassification with regard to the outcome. Those that should have reported the outcome but failed to report the outcome. Okay? So direct medical examination is always an option. In fact, this is what was used in the Framingham study, as I mentioned. So ascertaining of the outcome, you should make sure that there is equal opportunity to find the outcome in the exposed and the non-exposed. كتير مهم إنه if you are working on finding the outcome, you do it the exact same way in the exposed and the not exposed. Because if you're going to do a special treatment for the exposed versus the not exposed, then you're going to end up finding more the outcome in the exposed بالnon-exposed. انت عارف هذا الشخص عم ياخد مثلا لنقول blood thinner، وانا بعرف انه البلاد ثينر بيعمل البلاد ثينر بيعمل internal bleeding. Okay, so I have a group of people taking blood thinner, a group of people not taking the blood thinner. لما بيجي to evaluate if internal bleeding happened ولا لا، I may not do a very thorough examination for those not taking the medication. أما إذا حدا عم ياخد the medication, I would do a very thorough examination and I'd end up مش over لا I will identify مثلا all those that had internal bleeding in the exposed. However, in the not exposed, I might miss some of them because I'm not doing the same amount of effort. Okay, and therefore I would end up doing something called differential misclassification, which we will talk about بعد شوي. Okay, so when ascertaining the outcome, the most important thing is to use the same procedure for the exposed and the non-exposed. Otherwise, there will be differential misclassification. Thus, comparing general population to factory workers might bias the result. ليش؟ لأنه factory workers undergo a physical examination every year they're required by the faculty, which is not the case in the general population. هول population كل سنة بيروحوا لعند الحكيم and they get examined. So they might, if they have an outcome, it will show, it will be captured much faster or at a higher rate than in the general population اللي قاعدين بالبيت. They might have the outcome, but nobody's finding the outcome. Okay, so continuing with ascertaining the outcome, how about the quality of the ascertainment? As we discussed in the case control design, the quality of the method used should be addressed. كمان, depending upon if you watch the case control video or this video, it doesn't matter. What is important is that the method used to ascertain the outcome, yani to diagnose the outcome, should be an appropriate method. Okay, it should be a valid method. لأنه it should be appropriate because it will impact the validity of the outcome. مثلا, if I want to ascertain high blood pressure, hypertension, so is one measurement enough? إذا أخذت one measurement of a person وطلع معي blood pressure عادي, is that enough? Is that the way of diagnosing high blood pressure? What is the appropriate way of diagnosing blood pressure? I have to use the appropriate way. أو مثلا to figure out if somebody had a heart outcome, a heart event, is تخطيط القلب enough? ولا is there something that according to the guideline I should follow? Okay, so you need to think about what you're doing so that you make sure that you're actually doing the appropriate method. So مثلا كمان for mental health disease, do I use a set of question مثلا لنقول back depression questionnaire, and based on the back depression questionnaire بقرر انه هذا الشخص depressed ولا لا, or should I refer the people to be seen by psychiatrists and the psychiatrist will tell me if they are depressed ولا لا? Okay, and you can like think about any type of outcome. You have to ask yourself, did they ascertain it the appropriate way? Okay, so كمان, is there a blinding in the ascertainment of the outcome? Which relates back to the previous point. إذا بيعرفوا their exposure status, then the way they're going to ascertain the outcome might be impacted. كمان that should be also taken into consideration. Are the people ascertaining the outcome appropriately trained? What is their reliability? Okay, so that concludes how you're going to go about ascertaining the outcome. بضل في عنا number 6, which is the role of bias in this type of design, be it the misclassification bias, which is a type of information bias, the loss to follow-up bias, and the non-participation bias, which we will talk about. Okay, so here we're going to look at misclassification, and I kind of mentioned it before that misclassification happens when there's a mistake in allocating a person to their right group. So, مثلا, someone who's exposed, we're putting them in the non-exposed, or someone who's not exposed is put in the exposed. So this is misclassification with regard to exposure. Or someone who does not have the outcome is mistakenly thought that has the outcome. The other way around, someone who doesn't have the outcome or someone who has the outcome is missed. So that is would be misclassification with regard to the outcome. Okay. So what will that do to your measures of association, and how would that make a problem? Hello. In the case control, we mentioned that if you have misclassification that is non-differential, that will always bias the odds ratio toward the null. Don't worry about it if you haven't watched the case control video. But what matters here is I want to talk about شمعناتها non-differential misclassification. All right. So شمعناتها differential and non-differential misclassification. So non-differential misclassification of the exposure status happen when you're making a mistake with regard to the exposure, right? So you're removing a group of people, whether they are exposed and you're putting them in a non-exposed, or whether they're not exposed and you're putting them in an exposed. However, that mistake is done at the similar rate with regard to the outcome variable. Okay? We'll look at an example and we'll explain what we mean by that. So this happens when exposure status of the participant is wrongly labeled, but if the error happens at the same rate in those that develop the outcome and those that do not develop the outcome. Okay? Okay? So when this happens, then non-differentially, the bias of the relative risk is towards the null. Remember, كمان شو معناتها we're biasing towards the null. Remember, a relative risk or an odds ratio. According to the null hypothesis always state that the relative risk or the odds ratio is equal to 1. So when you bias a relative risk toward the null, that means you are making the relative risk, or you're making the odds ratio for that matter, closer to 1 than it really is. So maybe the true relative risk should have been 2. However, because of this error, the relative risk is being biased towards the null, yani it's appearing to be closer to 1 than it really is, and therefore your relative risk comes out to be equal to 1.5. The real relative risk would be 2, the biased would be 1.5. 1.5 is closer to 1, and therefore the bias is towards the null. Yani you're making the association appear weaker than it really is. So let's look at an example. So you remember then when you have a cohort design, you're looking at exposed and not exposed, okay? And the calculations are done within exposed and within not exposed. So within the exposed, 250 out of the 1,000 developed the outcome, and among the non-exposed, 200 out of the 2,000 developed the outcome. By now you should know how to calculate a relative risk. It's the 250 على 1000 يعني عندنا 25% risk in the exposed, and the 200 على 2000 يعني we have 10% risk in the not exposed. 25% over 10%, that's 2.5. The true relative risk is 2.5, and therefore the real relative risk is those that are exposed are at 2.5 times higher risk of developing the disease than those are not exposed. I'm بستعمل كلمة risk because I'm calculating a relative risk. So let's do something called a non-differential misclassification in the exposure status, and we're doing that at 20%. So هغلط in 20% of my exposed، هشيلهم من الexposure، حطهم in the non-exposure. Okay, so though they are exposed, maybe they are taking the medication, but I'm gonna miss that. I'm gonna make an error, and I'm gonna miss the fact that they're taking the medication, and I'm gonna end up thinking that they're not taking medication. What proportion of the 1,000? 20%. Okay, so removing 20% min 1,000, that's 200. So I'm gonna remove 200 from here, and I'm gonna put them down there. So I remove the 200. Now I have a total of 800. You put them down there, the total is 2,200. Now let's continue. This misclassification is said to be non-differential, meaning that this 20% in total, it's going to be non-differential between the disease and the healthy. In other terms, I'm going to take 20% of the diseased and put them down, and 20% of the healthy and put them down. So 20% of 250 is 50. So I'm going to take out 50. I'm going to put them down. So now I have 200 by 250. Okay. كمان I'm going to take 20% of 750. 20% of 750 is 150. So هشيل 150 من 750 and I'm going to put it down. So I end up with 600 here and 1950 there. Okay. So let's recap. This is the real table without any mistake. This is the table when I make a mistake. I'm making a 20% mistake where I'm taking exposed عم حطهم بالnon exposed. يعني عم غلط 20% من الأوقات with regard to exposure status and I'm put them in the non-exposed. However, that mistake is happening at the same rate whether a person has the disease or a person does not have the disease. And therefore we talk about non-differential. So when something like this happens, if you were to recalculate the relative risk here, yani 200 over 800 divided by 250 over 2200s, your relative risk is going to be 2.2. 2.2 is closer to 1 than 2.5, and this is exactly what we were saying in the previous slide. Non-differential misclassification with regard to the exposure is going to bias your relative risk towards the 1. So this is the real relative risk. This is the biased one. And you can see that the biased has been pulled toward the null value of the relative risk. And to pull value 1, it's right. That's it. It's going to be pulled towards 1. Okay. So non-differential misclassification of the disease status. So أول وحدة كنا عم نغلط بالexposure. Now we're هنغلط with regard to the disease. يعني we're following exposed and not exposed. However, for some reason, we're not detecting the disease as good as we should. However, الغلط, we're doing it exactly the same way, whether they are exposed or not exposed. This happens when among those that were exposed, there is an error in the disease status. When this happened done non-differentially, then the relative risk is not biased. That's the important thing here. When you misdiagnose, regardless if they're exposed or not, your relative risk is not going to be biased. However, the risk difference is going to be biased. Let's look at the example again. So again over here, I have the 1000 and the 2000, and again I have the 250 that developed the outcome and the 200 that did not develop the outcome, and therefore my relative risk used to be 2.5. وقلت لكم انه the risk in the exposed كان 250 على 1000 يعني 0.25. The risk in the not exposed كان 200 على 2000 meaning 10%. Okay, the relative risk is 2.5. However, the risk difference is 15%, and you can think about this as the attributable risk. The attributable risk is 15% or the absolute risk difference. طيب, let's make كمان an error of 20%. However, this time I'm making the error with regard to the disease. Okay, 20% of the time يلي عندهم الoutcome, I'm missing that and I'm thinking that they are healthy. So I'm going to move people from the disease, هحطهم بالhealthy. Okay, 20% of 250, as we said a moment ago, they are 50. So I'm going to remove 50 from here and I'm going to put them here. So you remove 50, you end up with 200, and over here you end up with 800. Same thing, you're going to miss 200 out of the 200, you're going to miss 20%, yani 40 individual. You're going to think they are healthy. So I remove 40 from here and I put them here. Okay, so you end up with 160 and you end up with 1840. Now, if you repeat your calculation, now you're going to calculate a risk in the exposed equal to 20% and the risk in the not exposed equal to 8%, producing a relative risk of 2.5. This relative risk is not biased. Okay, so misclassification with regard to the disease, to the outcome, if it's done non-differentially, and عم نغلط whether they're exposed or not at the same rate, your relative risk is not biased. However, your risk difference is biased. Look at the risk difference. It used to be 15%, it appears to be 12%. So إذا أنا عندي a group of people ناس that مثل ما كنا عم نحكي بالexample ناس that trying to remember what was the example. Yeah, taking blood thinner and those not taking blood thinner. And I'm diagnosing whether or not they suffered from internal bleeding. If my diagnosis procedure is blinded with regard if they're taking blood thinner or not. However, this diagnosis makes a mistake 10% of the time or 15% of the time. However, that 15% of the time happen whether they're taking blood thinner or not taking blood thinner. بما أنه عم بعمل misclassification with regard to the outcome يعني while diagnosing the outcome عم بغلط. However, this mistake is done non-differentially. So the rate of the error is the same whether they are taking exposed or not exposed, whether they're taking blood thinner or not. My relative risk will not be biased. Okay, my relative risk will be an accurate one. However, the risk difference would be biased. Okay. There is another type of misclassification which is called the differential misclassification. Differential misclassification, you are misclassifying, however, your misclassification, you're misclassifying differentially. And here, your relative risk could be either biased towards the null or away from the null. And I talk about the case control case here again. If you haven't watched that video, it's fine. So let's look at example where we are making a misclassification. However, the misclassification is differential. So بعدني with the exact same example and the same number 1000 و2000 and the same number with the true relative risk being 2.5. However, هعمل misclassification, هعمل differential misclassification in the exposure status. Like the first example, we're going to make a mistake in the exposure. However, it's going to be differential. يعني remember when I made mistake in the 20% here, I removed 20% from here وحطيتهم هون. I'm still making 20% error in the disease status. يعني مش in the disease status, I mean among those that get the outcome. So حشيل 50 حطهم تحت, that's 20%. However, in the healthy, my mistake is actually lower than that. It's 10%. And therefore, بما أنه the rate of mistake removing from the exposed, putting them in the non-exposed is not 20%, 20%, rather it's 20 and 10, then we talk about differential misclassification. And if I calculate the relative risk comes out to be 1.94. Now, in that specific example, it happened that the relative risk was again biased towards the null. بما أنه the real one can 2.5, the bias is 1.5, and therefore the bias was pulled toward 1, and therefore the bias is towards the 1. However, if I inverse the percentage in terms of the misclassification, so هالمرة I'm going to take only 10% of those حطهم تحت. So I'm only removing 25 and I'm putting them down, so leaving 25, 225 and 225. However, in the healthy, now I'm going to make a mistake of 20%. So I remove 150 بحطهم تحت, so 600, and I remove them down. If you recalculate the relative risk, it comes out to be 2.63, which is larger than 2.5. يعني this biased relative risk of 2.63 has been biased away from the null. Okay, so as we have seen, when you are making a misclassification that is non-differential, if that is with regard to the exposure, then your relative risk will be biased towards the null. If your misclassification, which is non-differential, is with regard to the outcome, then your relative risk is not biased. When you come into making a misclassification with regard to the exposure, if you're making it differentially, your relative risk could be biased towards the null or could be biased away from the null. More with the example. هالمرة هنعمل differential misclassification with regard to the outcome. Okay, so again, same exact example that we discussed previously. Again, I'm going to take some people that are that should have been diagnosed but I'm going to miss their diagnosis. So in the first example, I'm making a mistake at a rate of 20% in the exposed versus 10% in the non-exposed. So 20% of 250 is 50. حشيلهم من 250 حطهم بال 750. So you end up with 200 and 800. However, in the 200 اللي هن not exposed, the rate of the mistake is lower. It's 10%. So out of the 200, I'm going to remove 20 وححطهم بال 1800. So I end up with 180 and 1820. In that scenario, if you recalculate your relative risk comes out to be equal to 2.22. This time, your relative risk has been biased towards the null. لأنه it's a differential misclassification. كنا عم نقول لما كنا عملنا الإكزامبل كانوا non-differential 20% and 20%. طلع معنا relative risk non-biased. Here it is biased and it's biased towards the null. Let's reverse the rate. So let me put 10% in the exposed and 20% in non-exposed. Again, if you do the calculation, you discover 10% of 250 is 25. حشيلهم نحطهم بال 750. So that gives me 225 and 775. I'm going to make a mistake of 20% in this group, and I'm going to put them in the 1800. So that's 160 and 1840. If you calculate your relative risk comes out to be equal to 2.8. معناتها you're making a mistake that is away from the null. So I would like to point out an issue here. So remember when we talked about the odds ratio or the relative risk, Elna, if you think about it, it starts somewhere at 0. It passes through 1. This is the null value. يعني ما في difference. And it goes all the way up to a maximum value. If your relative risk or odds ratio is biased towards the null, يعني whether you are greater than 1 or less than 1, this is like the real one. The biased one, when it's biased towards the null, يعني it's appearing to be weaker. Weaker يعني closest to 1. Okay, so your biased could be appearing here or appearing here. هلا, whenever you are having a biased measure of association that is appearing to be biased towards the null, then in the case of the biased is still statistically significant. يعني تخيلوا هيدا البايست هون طلع معنا relative risk is equal to 1.8 والconfidence interval is going from 1.2 مثلا 2.4. So even though it is biased towards the null, it's still appearing, it's still showing up, and it's still statistically significant. You may talk about your results being robust. Because even if somebody reading your results and criticizing you and they say, well, you may have done a misclassification with regard to the exposure, you may say, okay, I may have done a misclassification with regard to the exposure. However, it occurred non-differentially, and therefore my relative risk, if it was biased towards the null. يعني بعدني أنا, if I declared that there is a relationship, and if you're saying that I made a mistake with misclassification, then my relative risk should have been stronger, and therefore my results not only I stand by my results, however my results should have been stronger, and therefore you talk about the robustness of your outcome. هيدا in the case إذا عملتوا misclassification that is non-differential. However, if your misclassification is differential, it's a different story. Then it depends if it's gonna bias towards the null or away from the null. Okay, so this is what I wanted to talk about misclassification and their impact on your measures of association towards the null or away from the null. Another problem is the loss to follow up. By mere fact of following a large number of people for a long period, a number of participants will be lost to follow up. They travel, they change address, they decide that they want to leave the country, they decide that they change their مثلا their health insurance, and therefore they can no longer afford coming to the clinic where you're capturing them. Anything that can happen. If the proportion of lost is in the 30 to 40%, then the validity of the study becomes questionable. It's not good. Usually you're going to have loss to follow up no matter what's going to happen. If you're reading any cohort study أو حتى if you're reading a clinical trial حيكون في lost. But usually if they are within a certain percentage, then it's not a big issue. The problem is when you start losing 30 and 40%. Loss to follow up becomes a major issue when the proportion of loss to follow up is different for the exposed compared to non-exposed. يعني عم نرجع لفكرة الديفرنشال بس هالمرة مش in the misclassification, rather in the loss to follow up. يعني if you go back to our if you go back to لما كنا عم نحكي about the cohort, okay, think about it this way. So you know in a cohort, as I mentioned previously, you have two groups. So exposed and the not exposed, okay, and you're following these up and you're following these up. So if you end up losing, so whole you're gonna lose them up, and whole you're gonna lose them up, okay. If those that you're losing in the exposed group are very much different from those that you're losing in the non-exposed group, you have a problem. يعني تخيلوا in the exposed group عم تخسروا مثلا younger people, all the one. In the non-exposed عم تخسروا older people. Then you have a problem. كمان يعني the problem would be even stronger in that scenario. So the researcher should do all in their power to minimize the number of loss to follow up. How do we minimize that? What can you do so that you don't lose a lot of people? You may get a contact of a family or friend member of the people that you're following. In case you lose them, you can contact their family member or your friend, ask about them. Maybe they change address or failed phone, and then you can find them, and maybe you can try to keep them in your study. Do multiple contacts ومش بس you send مثلا if the follow up is done through مثلا phone calling, try to call more than once. Have intensive to increase adherence to the study. مثلا بالفرامينغهام study, by the time انه صارت the study is going over decades, صاروا الparticipant عندهم sense of proud to be a part of the study. Facilitate to the participant their visits to the clinic if applicable. So as a follow-up requires visitation to the clinic, make it easier on them, and maybe give transportation fees, or maybe give them transportation buses, make it easier on them to come to the clinic. Make effort to document death if applicable. كمان لأنه part of the loss out of follow-up, maybe somebody died. كمان look for records, try to see what happens to them. Comparing the lost follow-up to those that are still in the study is a good idea to reflect on whether they are different from those that are in the study. مثل ما كنا عم نقول إذا أنا عم بعمل follow-up مثلا ل people taking certain medication, statin or whatever, versus those not taking, عم بعمل follow-up لهالstudy. And over time, I started seeing people that are I'm losing these people. Am I losing the most educated one? Am I losing the most healthy one? Am I losing the most لنقول physically active? هلا بما انه they were part of the study at the beginning, you may have some data on them that you can compare to those that remained in the study and see what happened to them. And therefore you can reflect on, am I losing a special group or am I losing just randomly? If you lose randomly, that's a lower problem, rather than if you lose a specific chunk. So also a worst case scenario of analysis can be done. So هذا الشيء فينا نعمله, and I'm going to show you an example كمان. This is similar, or actually it's a type of sensitivity analysis that you may have discussed in pharmacoeconomics. إذا ما أخذتوا pharmacoeconomics, you'll take that next semester and you will talk about sensitivity analysis. So what do you mean by sensitivity analysis? Test by how much the difference in occurrence of an outcome between loss to follow-up exposed compared to loss to follow-up in the non-exposed needs to be for the results to be changed. Let's look at the example. Everything will become clear. So originally, in this scenario I'm showing you now, originally كان عندي exposed 10,000 non-exposed 12,000. هذا total sample. However, I'm going to lose in the exposed 1,000 and I'm going to lose in the non-exposed 2,000. Okay? Among those that remained, the outcome came 15% in the exposed and 10% in the non-exposed, producing a relative risk of 1.5. مظبوط؟ لأنه the risk here is 15%, the risk here is 10%, you do the ratio, you get 1.5. هذا among those that stayed in my study. Then you can start asking yourself, those that I lost, what could be the risk in this group? And knowing the risk in those, how would that impact the risk that I have in my study? And how much that should have been an issue to a point where I lose this association. So let's see if I can make sense of this. Okay, so look at this example. كنا عم نحكي إنه I had a total ما هيك 10,000 ب 12,000 هول إذا ما في حدا lost to follow up. But I know إنه in fact أنا عندي 1,000 lost to follow up in the exposed and 2,000. So really in your study this is what you're seeing. You're seeing 9,000 versus 10,000. And in your study you're seeing 15% or as a risk in the exposed and 10% in the non-exposed. 15% out of 9,000 is 1,350. 10% out of 10,000 is 1,000, and therefore you calculate the relative risk, it comes out to be 1.5. Now you ask yourself, okay, so I know that I lost 1,000 in the exposed and 2,000 in the exposed. What happened in this group? Oh, in reality, you don't know, but you say, okay, let me play scenarios. Let me play scenarios of what happened and see how would that impact my relative risk. Yani, if those that I lost 10% in the exposed صار عندهم الاوتكم and 15 in the non-exposed. يعني خلينا نعتبر انه those that I lost عندي the reversal of what I observed here. هلا where did I come with this suggested reversal? It's a hypothetical. Okay? How would my sample would have been if I did not lose anybody? بمعنى آخر عندكم those that remained هول أنتم متأكدين منهم. Those that you lost, you give a hypothetical risk in the exposed and a hypothetical risk in the non-exposed, and then you merge them to get an idea of how would your results have looked like if everybody remained in the study. So in the hypothetical scenario where the outcome is occurring at the total reversal than in those that remained, when you combine them, the relative risk comes out to be 1.34. يعني بعدني I'm seeing an increased risk. And therefore I say, okay, fine, حتى لو it was as bad as this, my results are still valid لأنه أنا عم declaring an increased risk. How bad should it be in those that I lost so that I lose my relative risk? When would you lose your relative risk? When it's equal to 1. Okay, so you start playing scenarios after scenarios in the laws those that were lost to follow up, and every time you recombine and you recalculate the relative risk to see what's going to happen. This is called sensitivity analysis. Yani you're making assumptions about a group of people that you lost, and every time you're changing that assumption so that you see the impact of that assumption on your measures of association. Okay, one more time. أنا عندي group كان بالأساس عندي 10,000 ب 12,000. I lost 1,000 ب 2,000. Those that remained in the study, I know what happened to them. Those are not the problem. The problem is those that I lost. What happened in them? In real life, I don't know what happened to them. So let me make assumptions. Let me make hypothetical situations. And every time I make a different hypothetical situation, I come back and I recalculate the total relative risk to see what would happen. Okay? So here I'm showing you the setup where hypothetically I read it 10 and 15%. I have prepared an Excel sheet where I can actually change these rates of occurrence of the outcome in the loss to follow up. Automatically it will update the table, update the total table, and update the hypothetical relative risk. Okay, so let me start with the scenario where those that I lost to follow up are exactly the same as those that did not lose. اوكي، لو وضع اللوس تو فولو اب مثلهم تمام those that remained لازم يطلع معي الريلاتيف ريسك هو ذاته 1.5 لانه اللي خسرتهم مثل تمام يلي بقيوا معي. So let's try that. So if the risk in the exposed كان 15% and the risk in the non-exposed كان 10%, okay, so غيرت whole, automatically this table was updated, automatically these two were combined here, and you get a relative risk of 1.1. This is what we said, is that if those that you lost are exactly similar to those that you did not or you followed up, then you're going to get a total relative risk that is exactly the same as the one that you observed. طيب خلينا نبلش نغير هولي بالvalues here and see what happens to my relative risk. So instead of having 15 and 10, what if I had مثلا 10 and 10? If it's 10 and 10, then your odds ratio total is 1.45, which is not that much different than the one you observed. Type, what if it's 10 and 20? Here, if the difference is 20, which is quite different from what you have over here, then your relative risk is still 1.24. يعني بعد في association, but it's weaker. What if it was 10 and 30? Okay, if it's 10 and 30, I almost lost the relationship. What it was 10 and 40? Here خلاص I lost the relationship. So أنا researcher بعرف إنه those are the ones that I followed, and based on those that I followed I'm coming up with the conclusion that the relative risk is 1.5. I know that في 1000 ب2000 that I did not follow ما بعرف what happened to them. However, I can play different scenarios, and I keep playing different scenarios, and every time I play a different scenario, I change my relative risk till I discover that those that I lose, the occurrence of the disease has to be that extreme for me to lose the association. وهيك if somebody is criticizing my work, criticizing my article, by providing this, which is called a sensitivity analysis, I would be able to address their concern. I would say, by the way, my dear reader, if you are concerned about those that I lost to follow up in my study, I did a sensitivity analysis, and based on my sensitivity analysis, لازم the disease to occur 40% in the non-exposed and 10% in the exposed for me to lose the relative risk. Otherwise, I would still have a relative risk. Okay, so probably I will also put this on Blackboard, and you're welcome to play with different values, okay, and see what happened to the relative risk. Okay, so let's continue. Number 3, we need to worry about non-participants. Those are individuals who refuse to participate in the study from the beginning. والمنهم lost to follow up on الأساس قالوا no thank you, I don't want to be part of your study. In the nurses' health study, 172,000 married nurses were invited, only 122,000 accepted. The response rate was 71%. In the Framingham study, the response rate originally was 69%. يعني في عنا تقريبا 30% saying, no, I don't want to participate. مين إني هول 30%? How different are they from those that participated? Are they very different? Or are they not so different? كمان, that will cause a problem. منشان هيك, every time you're reading a study, you need to look at the response rate. That will give you an idea of what is happening in the study. So the problem arises from the fact that those who refuse to participate are most likely different than those who do participate in terms of exposure and outcome. The Framingham study, refusal had a higher death rate for the first 2 years. Those that قالوا Framingham, no thank you, we don't want to participate, in the first 2 years they were dying at a higher rate. That tells you what? It tells you that they had more complications. They had health conditions that was not present in those that participated in the Framingham study. Okay, So every time بيكون عندكم refusal to participate that is high, مثلا 50% refusal or 60% refusal, then you have a problem in your in the validity of your study. If non-participation is related to exposure status and disease status, it will bias the measures of association. In all other cases, it will affect the generalizability of the study, not its validity. Okay? يعني إذا الجروب that are refusing to participate هن group of people, okay? But it's not related to the exposure and outcome at the same time. يعني منهم those that are refusing happen to happen, those that are taking statin and have high bleeding. If these are the ones that are refusing to participate, you have a problem in the validity of the study. If not, then it's not a problem of validity of your study. Your study is valid. However, how much can you generalize? Maybe you cannot generalize to the elder population if the elderly is those that are refusing to participate. So in my example, I say meaning if MI was found to be associated to current smoking status in nurses who participate, the issue is not if the association is true or not, rather if the results can be generalized to all nurses. Rarely is there a direct assessment of non-response rate relation to outcome and exposure possible. So rarely we can actually look if it's related to both. One thing researchers do is that they compare the non-respondent to the respondent for general factors such as age, sex, education. يعني مثلا نرجع للنيرسز health study. So I know إنه عندي 60% 69% تقريبا 70% response rate و 30 refused. طب all that refused to participate, I do know a little bit about them because actually in the order of pharmacy, I have the general characteristics of all nurses. So if I compare my group that participated to the general to all nurses with regard to age, with regard to experience, with regard to specialty, with regard to other things, and if I find that those that participated بيشبهوا general population, then I have no problem. However, if those that refuse to participate happen to have special characteristics, then I have a problem. So I continue the note. If the two groups are similar, then the researcher can argue that there is no bias, meaning it to group those that accept to participate and those that refuse to participate. Example, the nurse health study info on non-respondent was obtained from the American Nurses Association. Researcher found that participants and non-participants were comparable to many variables, and therefore they said, well, you know what, those that participated with those that refused to participate بيشبهوا بعضهم, and therefore I don't have a problem with bias. So in recap, if those that refuse to participate are a specialized group, special group, you have a problem with generalizing your results. If not only they're a special group, but also they're related to the exposure and the outcome at the same time, هون عندنا مشكلة. Okay? So what can you do? Try to get as much information as you can from those that refuse to participate. Sometimes this information is available, مثلا gender, education, things like that. And therefore compare them to those that accepted to participate. And إذا ما في فرق, then you're fine. Okay? And this is true على فكرة for any kind of design. Any kind of design. في عندك refusal to participate, try to compare them to those that participated. So عم تعمل survey. You're calling people and you ask them to participate. حدا قال لك I don't want to participate. You can say, okay, can you but just, obviously I'm speaking to you and I can guess مثلا your gender. Can you tell me your age just for me, for records? And they're willing to do that. نحن عملنا مرة study in the south of Lebanon بال 2005. كنا عم نعمل measurement of mental health in Lebanon, in rural area that was under the Israeli occupation. And we went to specific villages and we were recruiting samples. So when we were doing that, sometimes we would knock on people's door and they would say, no, we don't want to participate. We said, okay, fine, we respect that. But do you mind telling us a little bit about the constitution of the household? How many members fee? How many males? How many females? The education level of the household, just for record keeping. And usually they give you few information. When the study ended, we compared those that participate in the study to those that refuse to participate in terms of gender distribution, age distribution, education, and they turn out to be similar. So we felt very comfortable saying that we don't think we have an issue with regard to participation bias because those that participated بيشبهوا those that refused. Okay. So in conclusion, you have a summary table for strength and limitation of cohort. You can read it. And that concludes the lecture on cohort in pharmacoepidemiology.